So sometime last year, as well as the other year, towards the end of the year, when we had the peak of COVID-19 hitting the world, I actually got a chance to work in the COVID department. And there was a time where we were expected to actually work in the ICU. At first, I was really scared because I had no idea how to work the ventilation machines. I had no idea what settings to use. I had no idea what CPAP was. I had no idea what BiPAP was until I actually got a bit acquainted with it, was shown how it works, and had a few read-ups here and there. And lo and behold, it became so much easier to use and actually to understand. So I thought I would actually start off by looking at the pediatric aspect of oxygenation and delivery of oxygen through various ways. I already talked about the oxygen delivery using the different oxygen apparatus machines, and I told you that CPAP will be a separate lecture on its own. Ventilation also, using the vents rather, will be mechanical ventilation, will be a separate lecture on its own. I won't cover much of that here. I will be focusing mainly on CPAP, which is continuous positive airway pressure. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at CPAP, or continuous positive airway pressure. If you haven't yet subscribed to the channel, please subscribe to the channel, hit the bell notification icon to be receiving notifications of such content every time I post. Sorry for the lapse in videos. I had fallen ill and I've just had this persistent cough that doesn't want to leave me. I hope actually I won't mess up this video and actually have to record it more than once, because I am literally not in the mood for that. All right, so let's go. So we'll first talk about respiratory support in neonates and in infants. Remember that there are some things that you can do actually when a child is actually desaturating, or when a child has oxygen saturations that are falling, especially with the newborn neonates. You pretty much want to stimulate them, tactile stimulate them, okay? Just stimulate them mildly. This can cause them to be irritated. It can cause them to cry. Remember, as the child is crying, the lungs are opening up, air is entering into the lungs. Of course, you should position their head positioning. You can put a towel over their shoulders such that their head is in the sniffing air in the morning position. If you have no idea what that is, just after this video, just have a Google of the sniffing air in the morning position, and you'll be able to actually see that. Don't forget to suction the mouth and the nose if there are any secretions, and just doing these three maneuvers can actually help you with saving the child. So remember that respiratory support in pediatrics, in neonates and in infants, can actually be provided through supplemental oxygen. It can be provided through continuous positive airway pressure. It can be provided through non-invasive positive pressure ventilation. It can be provided through bag and mask ventilation or mechanical ventilations, which are the vents. I won't talk about the vents in much detail. Remember, this lecture is just going to be focusing on continuous positive airway pressure. We covered the oxygen delivery systems in the previous lecture. I will leave it tagged at the end of the video. So remember that any neonate that cannot be oxygenated by those three maneuvers, or any of the above things, those CPAP, the non-invasive ventilation, bag and mask ventilation, mechanical ventilation, then you should actually search for other causes. You should do a full cardiac evaluation because they may have a congenital cardiopulmonary defect. You should treat them with high frequency oscillatory ventilation, nitric oxide, ECMO, which is the extracorporeal membrane oxygenation, or a combination of these things. And remember that you're not going to keep this patient on oxygen forever. There will be a time where you have to actually reduce the oxygen support using these methods. We call this as weaning. So it's a process where you gradually reduce the ventilatory support for the purpose of stopping the various forms of mechanical ventilation. So remember that weaning is going to be referred to either as a reduction in the amount of oxygen that you're giving. We call this as the fraction of inspired oxygen. So you shall see this FiO2. It's just simply the percentage of oxygen that you have. So for example, if you have 100%, it means that all the air that you're giving, or quote unquote, or the gas that you're giving is oxygen. But if it's 60%, it means it's 60% oxygen and other gases 40%. Then the volume, as well as the pressure, which is required, of course, to maintain adequate ventilation and or oxygenation. So if you have a reduction in the FiO2, the volume, and or pressure, then you refer to this as weaning a patient off. So remember, oxygen can be given by a nasal cannula or a face mask in terms of neonates, in terms of pediatric patients. And remember that the oxygen saturation should be set to achieve an oxygen partial pressure of about 50 to 70 millimeters of mercury in preterm infants and 50 to 80 millimeters of mercury in term infants. So it means if you're not able to check your arterial blood gases, you can actually use your pulse oximetry. And if it's a preterm infant, you're aiming for 90 to 94. If it's a term infant, you're aiming for 92 to 96. The reason why we're not really worried so much, even if it's reaching 90, remember that these infants have fetal hemoglobin, which has a greater affinity for oxygen. So even at lower oxygen partial pressure, you find that the hemoglobin is almost fully saturated. We generally want to avoid higher partial pressures of oxygen, arterial partial pressure of oxygen, especially in the premature children, because there is a risk of retinopathy of prematurity. Remember, too much oxygen can cause the formation of free radicals. And the oxygen should actually be warmed 36 to 37 degrees. It should be humidified, and this actually is going to prevent the secretions from cooling and drying, and this is actually also going to prevent bronchospasms. You can also put an umbilical artery catheter, which can be used to sample the arterial blood gases in the neonate who actually requires a fraction of inspired oxygen and FiO2 greater or equal to 40%. So if you can't really put this umbilical catheter, you can actually perform a percutaneous radial artery catheter, and this actually can be used for continuous blood pressure monitoring and blood sampling if your Allen test is normal. So remember that neonates that are unresponsive to the maneuvers, that oxygen that we've given, the tactile stimulation with the suctioning and everything that we've provided adequate resuscitation, then these may require fluids to actually improve their cardiac output. So assess if this child is well perfused. If they're not, they may require fluids to actually improve the cardiac output. These are actually candidates for CPAP. These are actually candidates for bag mask ventilation at about 40 to 60 breaths per minute. And remember that CPAP, whether it's delivered by a ventilator-driven or bubble type of CPAP, can actually avoid a child being intubated. I'll talk about the different types of CPAP very shortly. Don't worry much about that. And this actually minimizes the risk of them being ventilated and being intubated, and them actually having ventilator-induced lung injury. Even in the extremely preterm infants, we can actually use CPAP. It's actually advocated that in the preterm infants, you should start CPAP quite early. So if the infant actually does not oxygenate with or requires prolonged bag mask ventilation, then you have to intubate them. They have to be put on mechanical ventilation. And this is actually indicated for those that are very immature infants or neonates, those that are less than 28 weeks of gestation, or those that are weighing less than 1,000 grams. But of course, if you're in a resource limited area, you may not have vents in your NICU to actually put these children on. So most of these children actually don't really survive. And remember that this is because most of these are going to be lacking surfactant. So if you have surfactant, you can actually give them surfactant, and it sometimes does help. And because sepsis actually is a very common cause of respiratory distress in the neonates, it's actually a common practice that you should draw blood for cultures, and you should give antibiotics to neonates who have high oxygen requirements, especially those that are pending culture results. So we empirically treat them for presumed neonatal sepsis. So what exactly is CPAP? Remember that CPAP is actually going to be providing some sort of respiratory support. Remember that respiration happens in two phases. There is a phase of inspiration, which is an active process where you're drawing air into the body. Then there's a phase of expiration, which is a passive process. This is at rest, where you're pushing air out of the lungs. So CPAP is actually going to be producing a constant pressure, such that this pressure remains constant throughout the phases of inspiration. It's going to be constant throughout the phases of expiration. We're not really so much bothered about inspiration, but the key thing here is expiration. Why is this so? Because if you're constantly providing a force, a type of pressure, you're going to be preventing the lungs from collapsing. So what does this mean? The next time this infant takes a breath, it's much easier to inflate the lungs. So this is going to decrease the work of breathing in this infant. This is going to keep the lungs open and prevent atelectasis. So this is how CPAP is going to be working. So it's going to be providing respiratory support to neonates who have either upper airway obstruction or respiratory failure. And remember, respiratory failure could either be due to failure of ventilation or failure of the lung function. Then remember that CPAP is going to be providing this positive pressure throughout the cycles of respiration, throughout the cycles of inspiration, throughout expiration in a spontaneously breathing patient. This is very important. If a patient is not spontaneously breathing, don't put them on CPAP. They need mechanical ventilation. It's going to benefit them more than CPAP, because CPAP, it's not going to be triggered by the patient's apnea or anything. So if you put a patient that's not spontaneously breathing on CPAP, it won't do them so good. So remember that in a patient that's spontaneously breathing, the aim is that you want to open the lungs, the segments that are collapsed. You want, of course, to maintain the patency of the ones that are already open. So you deliver this constant pressure to the airway such that this infant that is spontaneously breathing has their functional residual volume or their functional residual capacity within the alveoli maintained, such that the alveoli do not collapse during expiration. And actually, this improves oxygenation, it improves carbon dioxide exchange, and also it improves the pulmonary circulation. So remember that during CPAP, you get this constant pressure. I will keep mentioning this, that you have a constant pressure throughout the respiratory cycle. And this pressure is roughly between 5 to 7 centimeters. You can reach a maximum of 8 centimeters, but if you plan on going beyond 8 centimeters, make sure you actually consult your seniors, you consult your pediatric consultant. Then, of course, there is no additional inspiratory pressure support. Unlike the other modes of the ventilator, where you have pressure support, you're not going to be having pressure support here. You're just going to be having this constant pressure throughout inspiration and throughout expiration. So when you use CPAP, like I told you, the most important thing is that the patient should initiate all their breaths. So you should ensure that this child is initiating, this child is actually breathing. And remember, if they're not breathing, ask yourself this: is the airway actually patent? If it's not and there are secretions, suction the child as much as possible, stimulate them so that they can cry and have these spontaneous breathing. So remember that when someone inhales air, it actually passes through the nose, it goes through the nasopharynx, it goes through the oropharynx, it goes to the larynx, the trachea, the bronchi, the bronchioles, and eventually the alveoli. And there's that exchange between the alveoli and the capillaries across the alveolar capillary interface. Now remember that these portions of the respiratory tract can sometimes be occluded by various things. They can be occluded by excessive tissue, they can be occluded by tonsillar overgrowth, poor muscle tone, they can be occluded by fatty acid axis, they can be secretions, among other things. So these actually, the forced air actually is going to be delivered via the CPAP, and it's going to keep these airways open regardless of them having these things blocking. And this prevents them from collapsing, especially during expiration. Because remember, during expiration, you get this in a preterm infant who already doesn't have surfactant. So again, the tension in the alveoli is very high and the collapsing pressure is high, so that when someone breathes out, the airways can actually collapse. And when the airways collapse, it means that the next inspiratory cycle is going to be even much harder than the previous one. So it means that the benefits of CPAP are going to include reduction in the work of breathing. I think I've already explained this. It's going to maintain a functional residual capacity. I've already explained this. So remember, functional residual capacity is a sum of the residual volume, which is the air that remains in your lungs, regardless of you breathing out maximally, plus your forced expiratory volume. So this is in short, when someone takes a tidal expiration, the amount of air that remains in the lungs after a tidal expiration, you refer to that as a functional residual capacity. So this is going to be preventing the alveoli from collapsing because it already has air in it. It also improves the alveolar recruitment, meaning it opens the ones that were collapsed, and it reduces the amount of blood that's going to be shunted. Remember that blood vessels in the lung work differently from blood vessels in other organs. Pulmonary blood vessels tend to vasoconstrict if you have no oxygen in that area, because there's no point of taking blood to that area, because the whole point of oxygenation in the lungs is so that the oxygen can actually diffuse into the bloodstream. But if you don't have oxygen because the lungs are collapsed, there's going to be this shunting of blood across the alveoli, and this is going to create a problem. So that's a ventilation perfusion mismatch. So you want to prevent this shunting through these atelectatic regions, and this should be in an infant that's spontaneously breathing. Another benefit is that it maintains the airway and it keeps it open. It also stabilizes the chest. So the CPAP can actually be provided with the nasal prongs. It can be provided with the mask and various other apparatus. But in our setting here, we actually do provide it with the nasal prongs. And in addition to this, it's also given using an endotracheal tube. So you can actually give it using an endotracheal tube that's going to be connected to a conventional ventilator where you set the rate to 0. So what are some of the CPAP devices? Before I actually come to the CPAP devices, I just want to first allude to how we can actually, the interface, the mask interface that we can use to deliver the CPAP. So in our setting, we use the nasal prongs. Remember, nasal prongs come at different sizes. Make sure that you have the right size for the neonate. Just don't make sure it's too big, because if it's too big, it can actually compress on the nares, it can compress on the septum, and it can cause pressure necrosis. So you just want to make sure that they're fitting directly into the nares. So this one's what's going to be used in our setting, the nasal prongs that are going to be fitting directly into the nostrils, or a small mask that fits over the nose. So you can actually give a nasal prong CPAP, or you can give it a CPAP via a face mask. So here you have a full face mask, and remember, this must be placed over the nose and the mouth and must have a good seal. It shouldn't leak. And then it can be used for those that are mouth breathers, those that breathe through the mouth, or for pre-oxygenation in spontaneously breathing patients prior to intubation. So we actually do this in theater. Before we actually intubate patients, we pre-oxygenate them, such that if there is a problem during the intubation, you already know that that pre-oxygenation, that extra oxygen that they took in, will at least keep them for a few minutes so that you can actually do other things and save the patient. You can also do this with the nasopharyngeal CPAP, which is administered via a nasopharyngeal tube, which is an airway that's going to be placed in the nose, where the tip is going to be ending in the nasopharynx. The advantage of this is that it's going to be bypassing the nasal cavity. It's also means that this CPAP is going to be delivered more distally into the respiratory system. So what are the 3 different types of devices that we use for CPAP? In our setting, the most common is what you're going to see is the bubble CPAP. So bubble because there are going to be bubbles that you're going to be seeing. It has this characteristic bubbling sound that you hear. Then you can have a ventilator CPAP in areas where they are resource rich. You may also have flow drivers. These are actually can be used even at home, especially for those that have obstructive sleep apnea. So bubble CPAP is what we use commonly in our setting. So here the flow has been altered to actually ensure proper bubbling. So you should actually alter the flow. So here, this one is a low technology. It's actually used in low resource limited areas. It's a way of providing CPAP using outflow tubing, which is just put into water. So we create an underwater seal, kind of like how the ICD works. But in this case, the pressure is going to be provided by how much you're dipping the tube in the water. So it's similar to the physiology of how an ICD works. So you just simply dip the tube, it's immersed in water to provide this expiratory resistance that is equal to the depth of the tube in the water. So the exhalation makes the bubbling in the water. So that's why we call it as a bubble CPAP. So the oscillatory pressure is actually going to be generated by the flow of the gas through an underwater seal system. Like I said, the bubbling is going to be produced by the flow of the expiration as the child breathes out. I'll show you the setup of how this actually looks like. This is the one that I'll go into so much details on because that's what we have in our setting. It actually uses blended as well as humidified oxygen with pressures that are typically between 5 to 10 centimeters. But like I said, if you're going past 8, you should make sure that you are informing your consultant, you're informing your seniors. Then you have a ventilator CPAP, which can have variable levels of descending pressures. You can have flow drivers, which maintain more uniform pressures. And remember that bubble CPAP has an edge over the other 2 types of CPAP. Number 1, because it's cheap. Number 2, because it's very easy to apply. And studies have shown that it's actually much more superior over the ventilator-driven CPAP in actually the management of preterm infants with respiratory distress syndrome. So here's what the bubble CPAP looks like. Here's a child on bubble CPAP. As you can see here, you have your oxygen that's coming either from a wall outlet, or it can be coming from a cylinder. Of course, it's going to be connected to one end of the nasal prong. Then the other end of the nasal prong is going to be dipped in actually water, a water bottle, which has, depending on the centimeters where you're dipping it, is the amount of centimeters of water resistance that you're providing. Then, of course, this is the nasal interface, or the nasal prongs, which are going to be going into the infant like that. I'll show you how you're going to be setting this up very shortly. Then of course, here is a CPAP machine, and here are the different parts labeled here at the bottom. Of course, this one here is an interface where you can actually set the pressures, and it even has a humidifier over there, where you can actually change and adjust the level of humidity that you want. And this is in more advanced areas type of CPAP. Then of course, this is a CPAP with a flow driver. Of course, these ones can be used at home in a home setup where someone has obstructive sleep apnea. But of course, the ones that we're going to be seeing in our setting are the bubble CPAP, the low budget ones in short. So there are some considerations that you should actually have for the infants that are on CPAP. So the first thing is you should perform a respiratory assessment. Ask yourself, what are the blood gases of this infant or this neonate? Determined by clinical condition, or you determine by previous blood gases? Are they acidotic? Are they hypoxic? Are they hypercapnic? What's the respiratory rate? What's the heart rate? Is the chest rising and falling? What's the work of breathing? Generally, the whole goal of you putting this person on oxygen is to reduce the work of breathing, to increase the oxygen in their body to the optimal amount, depending on the age. And then, of course, the oxygen requirement. You ask yourself, how much oxygen do they require? And you can do pulse oximetry, or you should rather do pulse oximetry, as well as a capillary refill time. You should maintain a neutral thermal environment, so they shouldn't be hypothermic or hypothermic. And of course, we should ensure cardiorespiratory and pulmonary oximetry monitoring, and we should set the correct alarm such that if in this child the saturation is less than 90 and it's, let's say, a term child, then the alarm should ring. Then of course you should document everything you do. In a child where you put in CPAP, make sure that you also put in a nasal or an oral gastric tube to ensure that you have this intermittent gastric decompression, because sometimes you can fill up the stomach with a lot of air, and this can actually cause the infant to have feed intolerance. So you should ensure hand hygiene at all times. This of course goes without saying in the NICU. And of course you should also, if you're performing an aerosol generating procedure, you should undertake these precautions to prevent droplet infection. So you should actually wear an N95 mask, or at least the duration of the procedure. And of course, isolate these infants from the other infants if they have very infectious respiratory conditions. So what are some of the indications for CPAP? So if someone has increased work of breathing, so how do we know this? Features of respiratory distress: tachypnea, nasal flaring, grunting, retractions. It could be intercostal recessions, it could be subcostal recessions, cyanosis, and generally if they have increasing oxygen requirements. If the respiratory acidosis is seen on blood gases, remember the normal pH of blood is 7.35 to 7.35 to 7.45. If it's less than 7.35, you're going to be terming that as acidosis. Then if they have increased work of breathing or acidosis with any of the following conditions that is not responsive to the usual things that you're going to be doing, the normal oxygenation, things like hyaline membrane disease or respiratory distress syndrome, pulmonary edema, atelectasis, apnea of prematurity just after extubation, transient tachypnea of the newborn, tracheomalacia or similar disorders of the lower airway, pneumonia or sepsis, bronchiolitis, mild meconium aspiration, even persistent pulmonary hypertension of the newborn. These are all indications for CPAP. What are some of the contraindications for CPAP? So remember, CPAP is not going to be used in individuals who are not spontaneously breathing. Remember, a child must actually be breathing for you to put them on CPAP. If they're not, then they need additional pressure support. They need a backup rate. So we can have what is known as BiPAP, which is bi-level positive airway pressure. It's another type of setting that you can actually use on these ventilators, and it's a bit different from the CPAP because the waveforms are a bit different. So those that have poor respiratory drive, these need invasive ventilation or non-invasive ventilation with CPAP plus additional pressure support and a backup rate. So essentially that's going to be your BiPAP or the bi-level positive airway pressure. If they have upper airway abnormalities that make CPAP ineffective or dangerous, such as choanal atresia, cleft palate, or unrepaired tracheoesophageal fistula. Craniofacial abnormalities are actually relative contraindications. In some cases, we may use CPAP. In other cases, we may not. Bronchopulmonary fistulas, no CPAP. If there is abdominal pulmonary pathology, such as diaphragmatic hernia or tracheoesophageal fistulas, we want to avoid CPAP. Now, what are some of the complications? Complications can either be related to the equipment or it can be related to the condition that the neonate has. In relation to the equipment, you could have obstruction of the prongs, which can kink, or the delivery circuit can actually kink, such that this child is not going to be adequately receiving enough oxygen. There can be inefficient delivery due to malposition of the binasal prongs or the mask. The skin can be irritated from the adhesive tape on the face. This is especially with the single nasal prongs, the ones that just have one prong that you put in one nostril. You have to strap it with some strapping or adhesive tape. So this can be irritative to the face. With the nasal prongs, they actually do have a hook at the back that you can actually move and actually fit into the neonate. Then you may have pressure necrosis around the nostrils and distortion of the nasal septum due to incorrect strapping and positioning. You may have pressure necrosis around the head or ears, and even head molding due to failure to release the hat and strapping regularly. For example, those that have binasal prongs, like I said, that hook that you have at the back that you can actually reduce or increase. Then there can be a high air leak around the prongs due to the mouth being open, or a single nasal prong, or with a binasal prongs, or even air escaping from the other nostril if you're using a single nasal prong. These are complications that are related to the equipment. You may have complications related to the infant's condition, so you may have obstruction of the single nasal prong or binasal prongs from secretions. You may have pneumothorax, you may have pneumomediastinum, you may have pulmonary interstitial emphysema, you may have a decrease in cardiac output. This is going to be due to a decrease in the venous return with excessive CPAP levels. Remember that you have the thoracic pump. If you're constantly having this high pressure inside the chest, it means that blood is not going to be getting back to the heart. You're going to have a decrease in the venous return, and if you look at your Frank-Starling phenomenon, this is going to translate into a decrease in the cardiac output. You may have gastric distension and feed intolerance. I talked about this earlier on. You may have increased work of breathing related to, of course, increased airway resistance. This is related to the diameter of the single nasal prong or the binasal prong. You may sometimes have inadequate ventilation. So let's talk a little bit about bubble CPAP in detail. So I'll show you how to set it up. I'll also talk about how to increase the CPAP, and then I'll talk about how to wean a patient off on CPAP before ending the lecture. So remember that the infant oxygen delivery tubes is going to be the binasal prongs, which are going to be serving as your CPAP circuit. So these are going to be having different parts. So there's an inspiratory limb, you have an interphase or your nasal prong, and you have a proximal part of the expiratory limb. Okay, so here is your nasal prong. So you remember that the nasal prong ideally will come like there will be one of these ropes here coming this side, another one coming this side. It will join together to form one tube that you're supposed to connect to the oxygen source. That's how a simple nasal prong actually works. But remember that here we have one part of the nasal prong that is cut. This part which is cut is the one that's going to be connected to the, or dipping in the water. You call this as the expiratory limb. Then this part here, which is connected to the oxygen, is known as the inspiratory limb. Then of course, this part here, which has the nasal prongs, you refer to this as the interface. So this part here connects to the oxygen. The oxygen is going to be flowing according to these arrows along this tube, as you're following my cursor, along this tube into the nasal prongs, then into the nose of the child. Then of course oxygen enters, carbon dioxide is coming out, and then of course it's coming out through the expiratory side, following the expiratory limb, and then into the water, causing the bubbling. So this is the setup. This is the tubing that's there. Of course, we do have special tubing that is set aside because of course you have to cut the nasal prongs for the CPAP. So it's a procedure when you're actually setting up the CPAP. Actually have a chat with one of the nurses and they'll show you how to actually set this up quite well. So remember that the proximal end of the inspiratory limb connects to the oxygen source. This part here is the one that's connected to the oxygen source, and then the oxygen or this part is going to be connected to either an oxygen cylinder, it can be connected to an oxygen concentrator, it can be connected to a wall piped oxygen, and then of course you're going to be having this interface over there which is connected to the baby. So your nasal prongs, which is the component of the oxygen delivery tube, comes in different sizes. Like I said, you should make sure that it firmly is applied to the nostrils, but you should gently adjust it with the strap around the baby's head. So again, as you can see, here's an oxygen outlet. Here you have the flow meter. This is the oxygen source. This is the humidifier over there. So you're going to be pouring distilled water into that humidifier. Then of course, air is going to be, or oxygen is going to be flowing through this tube, which is connected to these nasal prongs, enters into the inspiratory limb, goes through the CPAP interface. Carbon dioxide comes out of the infant, goes to the expiratory tube connected to this tubing, which is of course dipped in this bottle here, which contains water, which has some acetic acid. Sometimes you can use distilled water. So this provides some bubbles. Then of course, that's your bubble CPAP. So the CPAP generator is the cylindrical transparent bottle which is going to be filled to a predetermined level with distilled water, which is this one, the bubble generator. Then the expiratory limb of the circuit is going to be immersed in the bottle, and the depth in centimeters actually corresponds to the CPAP pressure that you're giving, so the centimeters of water pressure that you're going to be giving. So the tube is going to be secured with adhesive tape to this bubble generator to ensure that it actually doesn't move up or down, because if it moves up, it means you're decreasing the pressures. If it moves even further downwards, you are increasing the pressures. Then of course, once the setup bubbles are immediately generated when the oxygen valve is opened, then of course the chest auscultation is essential to confirm the presence of this bubbling sound. And if you don't get this bubbling sound, it means there may be a leak along the tubing, or the interface or the nasal prongs are not really fitting the child, or the baby's mouth is open. So if everything is okay, you should have some bubbles that are there, and it has this characteristic sound that you actually hear. So the initial response includes a significant improvement in your SpO2, your oxygen saturation, and a noticeable reduction in the baby's work of breathing. It's actually important that you should actually insert an NG tube to intermittently decompress the gut, and of course to prevent any gaseous distension. So how do we initiate CPAP? So remember, the first things first is we should ensure that the baby is breathing and the heart rate is above 100. If the infant is not breathing, or the heart rate is below 100 with the tone of the child being poor, in short, a floppy baby, we don't start CPAP. You should start oxygen. Start those 3 things that I told you about. Mildly stimulate this child, suction this child's mouth, suction their nose, start them on oxygen at 1 liter per minute. Check their oxygen saturation. If their oxygen saturation is less than 90%, start them on oxygen. Then of course, if the infant is breathing and they have a heart rate that is greater than 100 and they have good tone, they're an active baby, but they have this increased work of breathing, you should consider CPAP. For the neonates that are less than 1.3 kg, start them on CPAP early. If the respiratory rate is greater than 60 or the saturations are less than 90 with retraction or grunting, start them on oxygen first. If after 1 hour of you starting them on oxygen, they're still not improving and they have saturations less than 90, then you want to start them on CPAP with oxygen at 1 liter per minute. Or rather, you want to start them on CPAP if they have been on oxygen at 1 liter per minute. So here's a flow chart, because I know flow charts are going to be much cooler and actually much easier to follow for you guys. So here's a baby that's breathing and the heart rate is greater than 100. If the tone is good and the baby is active, if they weigh less than 1.5, start CPAP early. If the respiratory rate is greater than 60 but the saturation is less than 90 and they have these features of respiratory distress, first start them on oxygen. Start them on oxygen at 1 liter per minute. After 1 hour, come back and check the saturations. But it's not like you just put the oxygen and go away. No, you should be checking every 15 minutes, or you should actually be there during at least the first 30 minutes to see that at least the saturations are slightly improving or picking up. If they are not, then you should start this child on CPAP. If the child has poor tone and the baby is floppy, don't start them on CPAP. Stimulate them, start them on oxygen, suction them. So you should start them on oxygen at 1 liter per minute if the saturations are less than 90%. If you've started them on CPAP and they're not improving and you have the adequate CPAP, then you should consider an alternate diagnosis. But of course, I'm coming now how we're going to increase the CPAP to the different levels. So now we have started the child on CPAP. Let's say the child has a heart rate greater than 100, their respiration rate is greater than 60, the baby is active, but they're having intercostal recessions, subcostal recessions, and their saturations keep falling less than 90. I've started them on oxygen at 1 liter per minute, but with no improvement. Then you want to start them on CPAP. So the CPAP pressure should be optimized between 4 to 8. If you're going beyond 8, if you're actually at 8, you should have already informed your senior. Then the fraction of inspired oxygen can be actually adjusted to maintain the saturations at 90 to 95%. In our setting, there's very little control that you have of this fraction of inspired oxygen. The one that you can actually control is the flow rate of the oxygen, and you can also control the level of the water pressure. Then of course you have minimal handling, so there should be a judicious approach to interventions and investigations. And then of course the algorithm that I'm about to explain will now help you understand how we're going to be increasing CPAP in these neonates. Okay, so let me just zoom into this a little bit. So we want to start here. So I've decided to start this child on CPAP. So always check the connections before you increase the treatment. Make sure that the water is actually bubbling. Suction the baby once more, because if they have some secretions, this could be what's causing the child not to have saturations peaking. So you want to start your CPAP. You're going to be starting your CPAP at a level of 6 centimeters of water. Your oxygen flow rate will be 3 liters per minute. If you have a blended flow, it should be around 6 liters per minute. Then you check the saturations. Are the saturations improving? Are they greater than 90%? Remember, you should give this an hour. If they are improving, yes, it means that the baby is responding to treatment, so you continue the management. If they are not improving, it means you're going to increase the oxygen by 1 liter per minute. So coming from 3 liters per minute, you're going to now increase the oxygen to 4 liters per minute. So after 1 hour, you ask yourself again, is the oxygen saturation greater than 90%? You have now increased the oxygen to 4 liters per minute. If yes, the oxygen saturation is greater than 90%, you ask yourself another question. Is there substantial indrawings? Are there any recessions? Is there any retractions? Is there any increased work of breathing? If there is not, then the baby is responding to the treatment. You maintain them on the same 4 liters per minute of oxygen at 6 centimeters of water. If they are not improving, it means you have to increase the oxygen even further. So you increase the oxygen to 5 liters per minute. And remember that here at 5 liters per minute, that's our maximum that we can actually go and actually be safe. So we increase to 5 liters per minute. And then at this point, we should actually now start considering increasing the water level to 7 centimeters of water. And if you're using blended flow of oxygen, we can use it at 7 liters per minute. So at this point here, when you have reached 5 liters per minute, so increase the flow rate first. Then if the flow rate has reached the maximum, which is 5, then you can now begin to increase the centimeters of water. Once you increase the centimeters of water, then you ask yourself another question. Is the oxygen saturation greater than 90%? If it's not greater than 90%, if the answer is no, it means you now increase the oxygen to 6 liters per minute, and you can also increase the CPAP level to 8 centimeters of water if it's not already at 8 centimeters of water. This is now reaching a danger zone. That's why this box is even in red. So you must ensure that you call for assistance, because CPAP is not going to be increased past 8 centimeters of water without discussing with your seniors, without discussing with your consultant. Then of course you should reassess this chart for any alternate diagnosis. Then of course, after 1 hour of you increasing this oxygen flow rate to about 4 liters, actually 5 liters, is it 4 or 5? 4 liters rather, 4 liters of oxygen, and you find out that they have this substantial indrawings, recessions, retractions, and increased work of breathing, it means that even if the saturations are good, they still have work of breathing. They'll tire out. So it means you still have to increase the CPAP. If you increase the CPAP now to 5 liters per minute, you should consider increasing the water level to 7 centimeters and the blended flow rate to 7 centimeters. At this point also, reassess this chart for any complications, reassess them for any alternate diagnosis. Then you recheck the saturations again. If the saturations are greater than 90% and the child no longer has the substantial work of breathing, it means that they are responding to treatment. That means that you can leave them at that level. If they are not, then you have to increase the oxygen to 6, which is like the maximum, and 8 centimeters, the maximum, before you actually consult for help. So this is actually the algorithm of how we start and increase CPAP. I really hope that made sense. You can actually take a screenshot of this so that you can keep it for reference later on. So remember that for bubble CPAP, we first reduce the pressure to 5 centimeters of water. We actually even started much lower in the previous slide. We started at 3 centimeters of water if the saturations are maintained. Then we reduce the oxygen as tolerated if we're weaning them off. And of course, you can then change to nasal prongs if the oxygen saturations are maintained and there are no more apneic spells. This is assuming if we're using a face mask. And then if we're weaning them off, we want to first reduce the FiO2, which in our case will be very difficult to do. Then of course, remember that there is oxygen toxicity, which may be related to things like retinopathy of prematurity, bronchopulmonary dysplasia. So you want to consider changing to nasal prong oxygen if the baby copes at a pressure that's less than 5 centimeters of water. Then you can wean them off. So how do we wean them off CPAP? Remember that they should actually fit a certain criteria and they should fit all these boxes. Not just one of them, they should fit all these boxes. So number one, the patient should have at least been on bubble CPAP for at least 24 hours. So if they've been on it less than 24 hours, don't wean them off, no matter how good the response is. The second thing is that the respiratory rate should be less than 60 beats per minute for at least 6 hours. So if the respiratory rate is still greater than 60 breaths per minute, then you should still keep them on the CPAP. The oxygen saturation should be greater than 90 for at least 6 hours, and there should be no significant features of respiratory distress for at least 6 hours. So your golden mark is 6 hours. Then there should be no grunting, no recessions, no nasal flaring, no apnea or bradycardia. So here is the algorithm. So you ask yourself, does your child fit the criteria that I just mentioned on the previous slide? Have they been on CPAP for at least 24 hours? Do they have saturations greater than 90% for at least 6 hours? Do they have no features of respiratory distress for at least 6 hours? If the answer is no, you continue them on CPAP. If the answer is yes, then we're actually going to be, this is supposed to be decrease, not increase. We decrease the oxygen by 1 liter per minute. So this is not, it should be decrease the oxygen by 1 liter per minute, not actually increase, it should be decrease. So if the water level was initially more than 5 centimeters and the oxygen is more than 1 centimeters, or they have a blended flow rate that is more than 6 liters per minute, then we want to decrease the water by 1 centimeter every 6 hours. If the patient continues to meet the criteria, then you continue weaning them off until you reach a water level of 5 centimeters. Then you decrease the oxygen by 1 liter. So after you've reached 5 centimeters of water, so the water level is what you're decreasing first. Then we start now to decrease the oxygen. We decrease the oxygen by 1 liter every 6 hours. If the patient continues to meet the criteria, we keep decreasing until they have reached 1.5 liters per minute. Then of course, once the water level is at 5 centimeters of water and oxygen flow rate is at 1.5 liters per minute and the blended flow rate is at 6 liters per minute for 6 hours, if the patient is stable, then you can remove them off CPAP. Then you can put them on oxygen at 2 liters per minute. If a patient was already at a water level of 5 centimeters of water and an oxygen flow rate of 1 liter per minute and blended flow rate of 6 liters per minute, we can take them off CPAP and maintain them at 2 liters per minute. And remember, at any point, we must reassess the patient after 30 minutes, then hourly for 2 hours, then we can do it 2 hourly. Then if they meet the criteria for CPAP again, at any point you have to restart CPAP, and make sure you discuss with the seniors because it may be an alternate diagnosis that you're missing. So that's how we wean patients off CPAP. So what's the definition of failed CPAP? So if a child has a fraction of inspired oxygen greater than 60%, required to maintain the oxygen saturation between 90 to 95, then the CPAP has failed. If there's persistent pulse oximetry for premature babies less than 88% or term infants less than 92%, CPAP has failed. If there's respiratory acidosis with a pH less than 7.2 in the absence of any other metabolic disturbance and fully related to a raised partial pressure of carbon dioxide more than 6 kilopascals, then we can say that CPAP has failed. If they require apnea, if they have recurrent apnea that requires this mask ventilation, then the CPAP has failed. Then you have to note that the need of increasing FiO2, the fraction of inspired oxygen, and the pressure are actually signs that intubation may be needed. So if CPAP fails, you have to intubate this child. You have to put them on the mechanical ventilation. What are some of the complications of CPAP? We may have gastric distension and vomiting, risk of air leak syndrome, which is pneumothorax, reduction in cardiac output if there's increase in pressures due to the reduced preload by the increased intrathoracic pressure. Remember the mechanism in which the blood actually gets to the heart, the thoracic pump. Then you may have nasal trauma and necrosis, agitation, as well as nosocomial infections. I really hope you learnt a lot about CPAP. I know this might have been a mouthful for you guys, but if you did, drop a like, drop a comment to show some support. It correlates to the growth of the channel. Do not forget to share this content with everyone in the country so that we can actually spread the word to Zambia and beyond. My name is Dr. Moses Kazevu. Do not forget to subscribe. Until next time, bye-bye.